reconvene, we look forward in anticipation of the next segment, as mentioned earlier, the panel discussion, which is titled Challenges in Healthcare, a dialogue between providers and patient. We are delighted to have with us today a group of exceptional panelists who will bring together a diversity of perspectives, disciplines, and lived experiences in conversation with one another. I take great pleasure in introducing them to you. Our first panelist, Dr. Ashwini NV, is the founder-director of Mukta Foundation, which is an organization committed to preventing interpersonal abuse and violence such as child sexual abuse, bullying, dating violence, domestic violence, sexual harassment in public spaces, etc. She is also the CEO of Flourish Life School, a company that provides mental health solutions to individuals and organizations. She is the chair of Young Indians Bengaluru Rural Initiatives, which is a part of Confederation of Indian Industries for the year 2026. She is a trustee of Aweksha, a women's rights organization. She's a gold medalist in postgraduate studies in psychological counseling and holds a PhD in psychology pertaining to self-inflicted burns among Indian women. She was recognized as one of the 100 leaders under 30 from across the globe for her idea titled Focus, Formula to Foster Mental Health in Low and Middle Income Countries, at St. Gallen Symposium, Switzerland in May 2015. She is a recipient of Rotary Bangalore's Vocational Service Award 2018-19 for her work in the area of training and promotion of mental health. Please join me in welcoming Dr. Ashwini. I request Assistant Professor Dr. Akshata Bhatt to present a bouquet to welcome our panelists. I request Dr. Ashwini to kindly occupy her seat on the dais. Our second panelist, Dr. Amit Dais, MD, is an assistant professor in the Department of Preventive and Social Medicine at Goa Medical College. He completed his MBBS and MD in community medicine and went on to strengthen his training with a postgraduate diploma in geriatric medicine. He also holds a diploma in tropical medicine and an MSc in clinical trials from University College London, UK. He has several research papers in the national and international scientific journals, including the Lancet and the JMA. With over 25 years of experience in medical teaching, Dr. Dais has contributed extensively to public health research and practice in dementia care. His work spans Alzheimer's disease, adolescent health, bioethics, child health, mental health, and several other neglected public health issues. He coordinated the 1066 Dementia Research Group in India and was the former chair of the Nominations Committee for Alzheimer's Disease International, the UK. He is the founder secretary of Dementia Society of Goa. He was the nodal officer for information technology at GMC, former chairperson of Sangat, and members of several institutional ethics committee. Please join me in welcoming Dr. Dais. I request Assistant Professor Dr. Akshata Bhatt to present a bouquet to welcome our panelists. Our third panelist, Dr. Anjali Chaube, works as an assistant professor in the discipline of English at Goa University. She has completed her PhD and her MPhil from Jawaharlal Nehru University. Her research examines gender, diasporic dislocation, and theatrical representation, work that grew out of her own doctoral and MPhil inquiry. Her current research interest is in exploring textual construction of disability identity and its representational politics. At Goa University, she teaches postgraduate courses on feminism, drama, and disability studies, and supervises PhD scholars working on related topics. Please join me in welcoming Dr. Chaube. I request Dr. Chaube to kindly occupy her seat on the dais. The discussion will be moderated by event coordinator and in charge Department of English, Assistant Professor Ms. Clarinda Dice, whose depth of knowledge and keen analytic sensibility make them an ideal guide for the conversation that is about to unfold. I invite our moderator to kindly take charge of the session and steer our distinguished panelists through what promises to be the most stimulating and rewarding discussion.
Test. Yes.
Check.
Hello, check.
Check. Yes. That's loud and clear. Friends, it is my privilege to be surrounded by such erudite people from 3 different spheres, and we are going to connect today in a most productive manner. So, having somebody from the medical field, Dr. Dias, yes, we would like to discuss amongst one another, as well as have your opinions later on in the Q&A. The medical field has offered tremendous value to our society. We are nothing without members of the medical fraternity. And yet there are so many debates, so many questions that have come up regarding ethical practices, maybe costs, and so many other aspects that we would like to discuss with you today. And we look forward to this discussion.
Sure.
We also have with us Dr. Ashwini, who's doing tremendous work. Her area is working with victims of abuse, as we have seen, and we would like to hear more about this, and of course, your other points of view.
Definitely, ma'am.
Thank you. We also have Dr. Chaube, Dr. Anjali Chaube of Goa University. She's in the Department of Literature. And we would like this aspect too to be highlighted, because we have so many literary works that present both physical and mental illnesses through literature, through poetry, novels, memoirs, and this somehow makes issues pertaining disease, mental illness accessible to people, and we would like to have that perspective as well. Saying this much, I would like to throw open the discussion, and we will hear from our panelists, followed by a discussion amongst ourselves. Let's see where this goes. But sir, could we begin with you?
Okay, thanks a lot, Clarinda. I think what you rightly said, health is wealth. And ultimately, it's a goal of the healthcare community to ensure that everybody gets that physical, mental, and social well-being at the end of it. And it has been the goal of the WHO. You know, when we were studying, the goal for 2000, because we were studying before 2000, was health for all for 2000. And this now turned out to be, we had the Millennium Development Goals, now the Sustainable Development Goals. And again, in fact, this year, the theme for World Health Day is going to be on the global action for universal health coverage. Everyone, everywhere should get health care. There shouldn't be anyone who's not having health care, whether it's mental health care, physical health care. And the structures as far as the healthcare delivery system should be designed to ensure that everyone gets it. It's not that it was there, you didn't come, it's your fault. No, it's not their fault. It is our duty, because healthcare is their right, that we reach out to them. In fact, the National Rural Health Mission started in 2005. The whole focus was how to reach the rural areas and get to everybody, and to ensure healthcare is provided to everyone. We also need to think of those people with disability, those people who are vulnerable, those people from, say, a tribal area. We need to reach out to them as well. It is not healthcare to the elite, it's not healthcare to those who can afford, it is healthcare to everyone, everywhere. I insist on that. And there are barriers to this, and that's what we are here to discuss. The barriers that happen at different levels, barriers that happen at the hospital level, where you think that it cannot be affordable, maybe it's too expensive. You can have barriers because you think that maybe the care in that hospital is not very good, or you will think like in Goa, you have a very good healthcare facility, but often people say that the queues are so long and who's going to stay there, and this is the kind of thing that is there in people's mind. That forms a barrier. Ultimately, you do get to the same healthcare facility, but it is later on in the condition. So you delay and do not come on time. The other barrier is the distance. Now in Goa, we are very well networked, and so distance is not so much of a problem, but there are other areas in India where distance is a problem. Getting to a healthcare facility itself, you need to get someone else to be there with you. All those aspects affects whether people get healthcare or not. And the third and important barrier is the barrier from within, in that family itself. It's what you think about the condition. When you start making your own diagnosis and you say, okay, I can go on Google and find out what this is and come up with your own diagnosis. This can wait, or maybe I don't belong to that community that the hospital will take care of me. If I go there, they will not do it. So this kind of barriers that are there, lack of awareness, stigma that could be associated with that kind. What will somebody think? What if it is the C thing? What if I have some mental health problem? What will people think? What will my family think? I better hide it. And therefore, these barriers are there. So barriers at every level is something that we need to address.
Thank you. Yes. Could we hear from you, Dr. Ashwini?
Definitely, ma'am. Talking about the sector that I come from, which is working with survivors of child sexual abuse, dating violence, domestic violence, bullying. One of the major challenges that we've been experiencing at our organization is having mental health professionals, especially counseling and clinical psychologists, who are willing to also pitch in and do their bit when it comes to clients who are stuck within the legal systems also. Like say, for example, I have seen mental health professionals almost freaking out, because there is a summoning from the court and you need to go and give your, the testimony there. So I think one of the challenges is really that mental health professionals are not trained adequately enough to deal with the legal system, be it in the form of providing, the reports, be it in the form of, having to appear in front of the court. Sometimes, we've had clients who would say, I have only built rapport with you and there is no other support system. Can you accompany me to the police station? And I have nobody, And then the therapist saying, how could I don't know where the police station is and so on. So that's the real challenge. The other challenge, when Dr. Amit was talking about the distance, suddenly I remembered Bangalore traffic jam. It might seem like there is no concern with the distance, but then let's think about it. Imagine here is a domestic violence survivor. On an average from our data, we need 8 to 10 sessions to work with this particular survivor of domestic violence. Now, maybe this is a domestic maid. Now, would there be any house who would let her take off for 10 days to come to our counseling sessions? What that would mean is the therapist must also be willing to go where she is and maybe have some sessions when she is willing to come where the therapist is. But I also want to clarify how sometimes we think, let's go to the community where the survivors are. Let's give. But the challenge with survivors of abuse and violence is they don't want to be seen with us in the communities that they are part of. Imagine a dating violence survivor. Parents don't know that there was dating in the first place. And now there is violence. I remember, a case of revenge porn. Revenge porn is on a high. What is revenge porn? Let's say there is a breakup. Dissemination of intimate, the pictures, videos. A case, I remember, this girl would say, from my college to your center, it takes 2.5 hours one way. Yeah? And then you come to our house, my parents don't know anything about it. And then we need to figure out some other place. Now, how willing are mental health professionals to be part of a system where you don't know where your next working place is going to be? That's another challenge. The third challenge, it might even seem like really this is a challenge, but then it turns out mental health professionals, especially counseling and clinical psychologists, where talking is therapeutic and that's the foundational work, and with training in English that is happening, therapists saying that I can't counsel in Kannada, I can't counsel in this language, then it's becoming a very elite, the profession. You know English, I'll provide you the best of care. But you don't know English, I don't know what to do with my reflection skills. I think that's another barrier. Now, this is in terms of availability. But coming to, the acceptability, the concept of task sharing, task shifting, we did try at our the center. I know examples are no evidence, but this example is also reflective of one aspect of the reality, which is we trained it because we were getting clients in massive numbers and professional help was unavailable. In terms of funding, not available. So we wanted to also see if any other, the model works. In the mind of the clients, there is a hierarchy. Is it a clinical psychologist providing my service? Then maybe it's better. Okay. Is it a counseling psychologist? Still, it's better. But you are telling this is a volunteer you've trained. And this volunteer maybe is a survivor of domestic violence, somebody who is thriving right now. And yet in the mind of the receivers of our service, sometimes a hierarchy exists. So I would definitely also like to hear how to navigate, those challenges. The other challenge, I don't look at it as a challenge. In fact, that could be a solution in disguise, which is AI. I can tell it to you with certainty that the last 1 year, I've received at least 6 requests from companies asking for verbatim. Okay. Verbatim would be, let's say, a client and a therapist are dialoguing. Can you give us that recording so that we are going to train the AI to make exactly the kind of response that a human therapist is likely to? Now, I remember initially in my mind, it was like, hey, it's professionally, I want to be part of the solution, and now AI, it is okay. But then now coming to think about, the language barriers, if therapists are unwilling to learn the native language, they know it, but then because of years of getting trained in another language, they're forgetting. Maybe this is going to be a solution. So the AI coming to our space, I'm not sure if it's a challenge, but maybe it's a challenging thought for us to accommodate. Yeah, so maybe I'll leave at this, point, and then maybe a few more.
I don't know if you want me to just come in for this thing that you brought about task shifting. That is one kind of a solution to the problems that we have. I worked in the area of dementia, and we had this was like in 1999, 2000. We did an assessment to try to find out what is the healthcare gap as far as dementia is concerned. It was around 90%. 90% of the people who had this condition didn't have any sort of healthcare help in the family. The caregivers were totally burnt out, suicidal, and we needed to do something for them. We came up with the task sharing model and the task shifting model, where we trained lay health workers to be able to go to the houses. And we did a randomized control trial to find out whether this was effective or not. And we found that it made a huge impact on the quality of life of that person with dementia, also on reducing the stress in the caregivers. So it works, and in fact the WHO has a program called the MHGAP. I don't know if you know about that. For schizophrenia, for people with alcohol-related disorders, for people with depression, where they say that we need to reach out to people. If people cannot come to you, you need to see how you can reach out to people, and the different models and this is something that we need to grow up. I also agree with technology that can help us. But definitely above artificial intelligence is the human intelligence. So that cannot be replaced. It can help us, but it cannot replace, that human, and especially for mental health. You can't have a machine addressing the issues of mental health. It can help, but not really replace the human intervention.
Yes, thank you.
Yeah, so it is definitely better than nothing. That's the way it is. And things like language barrier is a big barrier, especially for therapies that involve a lot of talk. If you don't have that language, and it's not enough to just know the language, you should be able to speak and connect with that person. So you should know the language well. So therefore, we need to use these kind of services, but probably whether that is the only, that's a complete replacement for human beings, that I would not agree with.
Okay.
But
let's hear from Dr. Chaubey.
Yeah, it's very tough to situate my discipline within this discussion that is happening, which is rooted in the field so much. Nevertheless, looking at literary studies from the politics of identity, creation, and the question of representation therein, um, you know, for a very long time for us, literature was a white male story. We were told that this is the canon, and the white male's experience was the universal norm, and we all sort of understood and internalized and sort of tried to live that out. But as the discourse and the discipline progresses, what we have realized is that the universalist constructions of the norm, whether it's the gender, whether it's the value systems, whether it's the conditions of ablement, these are all these are all very problematic when it's imposed to people from different experiential realities. That's one thing that, how we sort of challenge the canon, the received notion of what constitutes literature. And late 20th and early 21st century onwards, we have tried to push the limits of the discipline to understand that how does the story become a black story or a women's story or a disabled story that way. In the context of the present, what we are doing here, we are trying to understand that within an environment which is very, very health obsessed, or nobody wants to be ill, nobody wants to be disabled, but this is a necessary condition of human existence, that we would all come to the point of either being too vulnerable or not being in control of our lives and our have complete control of agency over our body. What next? So this discussion is a very long drawn, there's so many perspectives here. But so far as the understanding of chronic illness and disability is concerned, what it brought us, what it brings us to a very important conversation, that the universality of the health discourses itself should be sort of problematized and challenged, and for the fact that the ill body is not an invalid body, or a disabled body is not something should be behind the scenes or not be spoken about. Say, for instance, those from literature background would relate to this. Bertha Mason's story, that mad woman in the attic. It's okay for the governess to marry her employer so long as his wife is disabled or mentally ill, and then she's hidden behind the scene. We never hear of what is happening in that story, Jane Eyre, that way. So likewise, there are so many other stories, so many other narratives that would foreground that the ableist constructions of the mainstream literary discourses. And in the present, what we have here is that a lot of life writings, memoirs, poems, and other varied kinds of engagement with lived experiences by people who have experienced this up and close and firsthand. And it sort of brings us to the question of what Dr. Ashwini and Dr. Amit were talking about, that it's not just about the privileged whose voice and whose experience is worthy of discussions here, and the fact that these narratives, when reported, it would be whether a doctor-centric report or a patient-centric report, or giving agency to one over the other, and the fact that we are all locating it within a systemic discussions of caregiving, disablement, and a whole lot of other things that come out of our engagement as humans.
What I find interesting in what the three of you have said, somewhere along the way, especially in the first two speakers, community seems to be having a bigger role to play now, okay? Because earlier on we've heard our keynote speaker too talk about how the doctor was a godlike figure. And today we have, and we need the help of community, people maybe who may not be as trained to be trained, okay? I would like a kind of, some kind of discussion to happen on the role of community in improving the situation, whether it comes to physical health, mental health, for that matter, even community writing? Could we have some, because we have lived experiences shared in memoirs, could we have writings of a community coming through in literature? So does community, can we focus on that for a little bit? What kind of a role would community play to strengthen the situation?
Sure.
Or
So
to improve
I
the
think what you
situation?
rightly said is that, yes, there is one area that we're developing the medical care and we're developing doctors training. In fact, now the new curriculum will train doctors in ethics and empathy. This is kind of part of the training. We need to focus on community. There is levels of healthcare, tertiary, secondary, primary. But I would say there's a fourth level as well. And the fourth level is in the community, where there has to be awareness in the family itself. In addition to this, the community outreach through various national health programs or national health mission is to train health workers to reach out to them, like ASHA workers in different areas, where you're training them, you're also incentivizing them for whatever work that they're doing. And in this way, we can actually use the community. They understand the community better. They understand the social practices in that area. They understand the stigma that people would be having. They can help with overcoming the barriers that probably a doctor may not be able to do, but then the community health workers can do. So if you want to bridge the gap, community health workers has to, and there are various models that help to do that.
Dr. Dias, I'd like to interject there. Our keynote speaker did say that Goa is the only state has not been able to implement the ASHA worker model. What is the reason for that, if we could know from you?
It's very difficult. I mean, I'm trying to figure out that myself. And in fact, I was speaking to Dr. Vikram about the same thing over lunch, where we were trying to find out why is it that in Goa. So I think in the beginning, probably people felt that our indicators are very good. Infant mortality rate is like comparable to that of the Western countries, most developed countries. But that is not all that is there. So it's not only infant mortality. We also have a high degree of, say, mental health problems would increase. I have done the study on with the ICMR called the INDIBE study on diabetes, and the diabetes prevalence is 26.4% in Goa. The prevalence of diabetes as a non-communicable disease has increased. So if we had these outreach workers, through them we would be able to address a number of issues. So I think by looking at some of the indicators, people felt that probably we don't require ASHA workers over here. Probably, thinking back, I would want the policymakers to rethink on that and reconsider that decision and probably get the ASHA workers back in this, because a very useful way of reaching out to a lot of people.
Because I also know that you work in geriatrics as well. So even there, Goa has a high number of aged population.
It does.
And
So
it could work in such a brilliant way
Yeah,
if we had these ASHA workers.
True.
Yes.
True.
Madam?
I'm just thinking, see, the way to promote mental health in my mind is by preventing abuse and violence. And there I shall bring in, the community, the perspective. Usually we think of how there are 4 approaches to prevent violence itself. One is victim-focused approach. Let's say we are talking about child sexual abuse. The easiest is go, meet children, empower them on, identify warning signs that somebody is an abuser. But can you imagine a child who is empowered but lives in a family where parents are not empowered, the grandparents are not empowered? That child going and reporting will also not lead to anything in terms of reporting or psychological intervention. So the first is victim-centric approach, which has its limitation. The other one is perpetrator-centric approach. But where do you get there? Maybe we need to enter the prison system, but the limitations of mental health professionals getting access there is also limited. The other one they say is situation-focused approach. Put CCTVs everywhere. Till in Bangalore, there was a case where the guy who managed the CCTV turned out to be the abuser and then had deleted the entire footage. So that too has limitations. So victim-focused approach has limitations, so does perpetrator-centric approach and situation. But the fourth one is the community-focused approach, where you leave nobody from this dialogue. You meet adults, sometimes I've also been asked, okay, you're addressing hundreds and thousands of people in the community, but what if there is a perpetrator there who's learning now about, ways to prevent? But what's wrong? Imagine there could be a perpetrator because we've not had the opportunity to assist. But that potential perpetrator now knows that just the way I know, there are thousands of other community members who are aware of these nuances. So I think community-centric approach where children are also part of, perpetrators may also be part of, I think is the ideal way to especially talk about abuse and violence. And I'm also thinking that should also be the approach for mental health related endeavors as well.
Definitely agree. You know, you need to empower the community. It's not only going to be able to handle the problem once it occurs, it can even prevent the problem from occurring. When the community is empowered, like, you know, in your case, the abuse, but sometimes people normalize abuse. They think that's a normal thing to happen. Till it's really somebody just comes out of it and says, okay, enough is enough and I need to go and complain about it. But why did it allow it to happen for so long? Because the community who saw it happening also probably allowed it to happen. So once you empower the community and create more awareness, I think that is one way forward too.
Yeah, and abusers thrive in silence.
Yeah.
And one of the most effective way to break that would be to talk about it, and what better way than community at large.
Yeah, even in my readings, this is the pattern that I have observed, that a victim of abuse, whether it's sexual abuse or physical violence, they take it on themselves, the blame of what is happening to them. And for the longest time, they would not approach anybody because they tend to be ostracized for what happened to them. And therefore, it's important for us to understand, to break the stigma and the taboo and the silence around some of these problematic aspects of our human existence, and to say it for what it is. Say, for instance, recently one case that came to light and which made, it's an international case of Giselle Pellicot. She's a French woman, and her it was her husband who was sort of bringing strangers home, and you know, she was drugged and raped for over a year by known people, and then last year it came out in the news, and she deliberately chose the stance of not being anonymous on her media trial, and she said that I'm a woman in my 70s, this happened to me, and this happens to children. And about time we start to put the blame where it belongs, and that too on the perpetrators rather than the victims. And that became an iconic trial, and it would also sort of set a benchmark for how these things would be treated in other places as well as legal systems.
You have a question? Yes? Could we have a microphone going there?
So it gets difficult how we get the victims out of this circle or the bubble they are living into. Because I have around 3 families where even the family, like the girl's family, says, Baba, get out of it, we are here to support you, we are here to support you. But in like a week's time, she's back again. Sure. And she goes running back. And then we become a taboo as we are trying to separate families. We are trying to break families and things like that. How do we as psychologists or people who are dwelling into this field like cater to people or victims like this? It gets really difficult.
I mean, a couple of the reading suggestions. You know, one is there is this idea called psychological entrapment. See, psychological entrapment, sometimes even any of us could have experience. Let's say a friend suggested you to watch a Netflix series. Let's say you began to watch and you're not liking it. And another episode, you're not liking it. The wise thing to do is to end it, but no, we need to see it till the end. See, a lot of times, you know, I've seen survivors of domestic violence, in order to honor the lost time, the efforts that I have put in, unconsciously they're losing even more time. You know, so that could be one thing. I have spent 5 years, maybe in 1 more year things may get better. Another 10 years now. You know, that could be. Psychological entrapment is the idea that in order to honor our efforts, the time, the intent you've put in, sometimes unknowingly we are losing further. The other thing is I would strongly recommend read up on the work of Dutton. There's a cycle of abuse. In cycle of abuse, what we see is, if it is conflict between adults, what happens? Both the parties, after they've had a conflict, they're going to take some time to cool down. Whereas, the abuser, what are they likely to do? An incident of assault happens, let's say. Immediately, maybe they are seeking reconciliation in the form of an apology. Oh my God, I didn't want to hit you. I love you, but then my boss troubled me, and then I didn't know where else to go, and then I displaced it on you. Or to even say something like, I didn't mean to, but what you did made me react in this particular manner, which quick reconciliation efforts followed by a period of calm, what they call the honeymoon phase. That may not last long, but then will last in the memory of the victim. And maybe the survivor is thinking that if this person could display such loving behavior, maybe I did something in order to be abused, because this person is capable of being loving. But then after that, what happens? Once again, incident of abuse happens, reconciliation happens, and then there's also a period of calm, and then stuck in that cycle. So the victim is likely to think maybe that period of calm at one point in time will continue to be the case without that becoming a cycle. So maybe that's something that we may have to explore with the survivor, if they are stuck in the cycle of abuse. If so, psychoeducation awareness is the first. And there's also something else, battered women syndrome, read up on it. Many of them, and research is also telling that, which is most women are losing their lives during an attempt to move out of an abusive relationship. When they are, that relative perception of, if I'm in this relationship, maybe I'm safe, but if I make an attempt to move out of the relationship, maybe it's going to be detrimental to my life and that of children also. So maybe these circumstances we really need to, but what we've seen is with time, with building resources, both inner as well as external resources and awareness of the law, and with time, most importantly, it is possible, as long as we are evolving a comprehensive safety plan. Nobody chooses violence, to live with violence, but not knowing the options is sometimes why people stay stuck in a violent relationship, and we've seen people losing life. My doctoral work is on women who burn themselves. You won't believe, in 1 year, in one hospital in Bangalore, I found 327 women's data, mostly trying to escape domestic violence. Now, this is self-immolation. Even today, yes. Maybe the numbers are higher. I collected data a couple of years ago. This is self-immolation to escape domestic violence. But those who are being burnt, the numbers are even higher. So when people are fearing for their life, it's not an exaggeration in domestic violence. Sometimes I'll be in this, maybe then I'm going to live longer in violence, then attempting to get out might even get me killed. Those could be the real fears.
Yeah, sir.
Absolutely, absolutely. So, the research is very, very strong. Read up on response-based narrative practice. There's a lot of evidence, yeah, sometimes I've seen awareness that, oh my God, I'm stuck in this cycle, and in a week I've gone through this cycle 5 times, then who am I even lying? But awareness is the first step.
The perpetrator can be very manipulative, so that's what causes the problem. It's like a narcissistic behavior, where they make you feel, as Ashwini rightly said, that you are the cause for this thing, you deserve this, that's why you're getting it. And they also start feeling that way. So then they feel the stick on, and this person will not let that person leave and go away, because they get pleasure out of doing this. So they'll have these honeymoon periods when between everything will be nice, they'll be very well behaved, and they feel, okay, things have come back to normal, and then once again you ended up in the same cycle. So that is a problem.
I'm reminded of the movie Thappad, where with one slap, she puts her foot down and decides, this is not for me. If you've done it once, for whatever reason it may be, you can do it again. And a movie like that, and the power of art and cinema and
Correct.
literature,
Agree.
you know, it has a tremendous role to play in shaping attitudes, in shaping how people see domestic violence.
Positive way as well as a negative way. Also,
Absolutely,
yes,
absolutely. Yeah. Yes, yes, more than domestic violence, yes, absolutely. It is at a party, yes, and but it is accepted otherwise. You know, oh, it's just one slap. Yeah, absolutely. But that movie, I think, made its presence felt, and yes, yes, yes. So literature and movies and cinema has a major role to play. Would you like to talk about that a little?
Definitely. You know, I'm just engrossed in the stories, lived reality so much that, you know, I just want them to talk at this point. But yeah, I mean, this is our mainstay in terms of, you know, literary inquiry of what, you know, telling a story publicly in a medium that has such a wide reach. Story like Thappar or Lipstick Under My Burqa. You know, these movies represent women as, you know, with agency, taking control of their lives, and, you know, understanding their worth and their value, that, okay, this cannot happen to me, or the fact that I deserve more, a better life, and perhaps things are not all dark and gloomy if I get out of this situation, because the illusion of a happy life, it's something that we are chasing, which is sort of a desire inbuilt from patriarchal upbringing, where marriage and motherhood is something that is supposed to give us you know, a coherent identity. So if you're not a mother, if you're not a wife, who are you? That is the question that these women are grappling with, and therefore I think they find it convenient to stay back in their gendered roles, that is the normative, you know, the normative gender roles, because that gives them acceptance. You know, they're putting up with abuse, they're putting up with a whole lot of, you know, mistreatment, but at the same time, they're also accepted in the society. And I think that social acceptance is very, you know, that pattern is very inbuilt within the way women are raised socially, and in the family, and they sort of grow up looking for validation and acceptance throughout their lives. This is something that we also look at within gender studies to challenge this bit, that can women exist outside of their gender roles, and what would it take?
Absolutely.
Dr. Anjali, you know, listening to you, I was just reminded by something that one of my clients said. This is many years ago. I think I had not started Mukta Foundation by then. She was a survivor of domestic violence. I remember she told me, years ago, it seems she had read a line. I could be stating it wrong, but then she said, Ma'am, I remember reading some book, maybe you would remember, that line is, to live is to suffer, and to survive is to derive meaning from that suffering. And she said, I just don't want to survive. I also want to thrive. You know, but that line had such an impact, positive impact on the, the mind of my client, that it was almost like a chant for us, session after session. And what she was, when I say domestic violence, it was the father who was sexually had abused her as a kid. So for her, it was like, my mom loves him, but you know, the complexities of those dynamics were, and she would say this line, to live is to suffer, to, you know, survive is to derive meaning out of that suffering, and I'm not just a, and that came from a book. So that value of literature in the life of somebody wanting to heal, I think thanks to what exists in literature and people like you who make it accessible to wider audience.
But even literature is not devoid of, you know, problematic representations. Even authors who seem very, very progressive in their works can be very, very problematic in their personal, private spheres. Because you mentioned daughter being abused by her father. You know, recently Alice Munro's story came to light, that Alice Munro is a celebrated author from Canada, and her daughter was being sexually abused by Alice Munro's boyfriend throughout, and she knew about it, yet she chose silence. She did not address it, or she never confronted him. And the daughter has now come out with her own indictment of her experience therein. So, it's yeah, the pendulum keeps swinging.
We're open to a few questions. Yes.
So you spoke about the community approach, right? So what came to my mind is, now if you see, a community approach will be very easily implemented in a rural small village, or a state like Goa, for suppose. But if you think about a metropolitan city like Bangalore or Mumbai, there are different communities there. There are different types of people there. There are different levels of status levels there, and not always, like someone mentioned, that not always people will stand up for someone other than their community or other than their social level. So like if they see some poor people, children being abused, not always a man who's with high status will go and stand up for them in the community if it's happening in their area. So what could be something that we could initiate to cover that community gap, to cover that gap in one community, especially now that we are globalizing at such a big level, such a big scale?
Yeah. So first you need to understand what are the healthcare needs of different people at different community and different settings. Now the person who's at the elite may have access to very good healthcare and would not necessarily need somebody from the community to come to their house to be able to address the needs. But there are others. So when you say urban area, the urban area is a total mix. When I said there's the National Rural Health Mission, then the government came up with the National Urban Health Mission, and now the two of them have merged to form the National Health Mission. So we have health workers in the urban areas as well who will reach that. You're right as far as the barriers are concerned, that not everyone would want to mix up with everyone, tu kaun maka sangpak type of thing. Who are you to tell me this thing? I know better than you. Yeah, but there are others who this can help, and there are ways to be able to overcome this barrier, but it is definitely needed. It's needed in a rural area, it's also needed in the urban area. The urban areas have slum areas, and I'm not talking about only the slum area, the other areas also require that. So we need to develop on how we have services and also have meaningful services that give us good outcome, so that everyone at the end of the day will thrive, as madam said, so. Correct. Yeah, they should. So we would address things like PTA sessions. Yeah, but getting them there sometimes becomes a challenge. Getting the parents, because they are working, also becomes a challenge. Yeah. Correct. Right.
Just one other the thought in response to what you asked, and in your question also you also use the word awareness. Solution was there, awareness. Something that we've tried through Mukta Foundation is collaborating with what's called community radio stations. The government has certain number of licenses to be given to each state, I believe. I'm not sure of the exact numbers, but then the licenses are usually given to NGOs and then universities. So community radio station covers a very limited radius of, let's say, 10 kilometers, but for a community that's huge. Yeah, we did one collaborative initiative through this radio station called Radio Active, which is a community radio station wherein we did 15 episodes on prevention of child sexual abuse. Now I'll tell you, I mean, the response that we got, sometimes it would be, a radio, an auto driver, sometimes it would be like a rack picker, community. So it reaches to those groups that otherwise you may not have. So maybe exploring ideas such as community radio station, I feel it's very powerful and an underutilized resource in the country. The tagline of most community radio station is for the people, by the people. And it's very powerful. The dialect, it could be something that's applicable to that 10-kilometer radius. I think community radio station is a huge possibility.
And using phones also now, WhatsApp and social media to be able to reach out to people, irrespective of who they are, I think you can create messaging accordingly.
So I think one more question. Yes.
Two people.
Okay, we'll take two. There's one here and there's one at the back.
Okay.
Yes.
A really lovely session. What I wanted to say was there is a book in the literary canon which recently won the Booker Prize by Banu Mushtaq called Heart Lamps. Now, it sounds very lovely, but when you find out why it is called Heart Lamps, it is actually self-immolation, which you were talking about, ma'am. Like the wife, she's trapped in a very abusive relationship and she's about to, she has dipped herself in kerosene and she's about to light herself, but then her child comes and hugs her and then she stops. And you realize that this is a a lot of stories are there inside. It's a collection of stories and how it's a very shared experience among women like that who are trapped in this traditional mindset of other people. And when you go, especially as a foundation, when you go to them and then you tell them that this is wrong, and then they tell you back that you are destroying our culture, our traditions. So how do we navigate with tradition? How do we navigate with awareness properly so that we don't feel like we are a threat, but we also make them aware? Because Banu Mushtaq does a really nice job at highlighting how tradition is so very bad for women, especially those who constantly are closed door abuse, I think it's called. Closed door, abused closed doors. So that.
See, I think one thing is definitely, see, anytime you go to the community, if you take this hierarchical approach that I am there and you listen to my perspective, I think nobody will ever be receptive. I mean, let's face it, even between children and parents. If parents say, hey, listen to me because I am the parent, the child may pretend to listen, but behind our back, I mean, as children, we know what we've done maybe. So therefore, I think when we go to the community, I mean, be part of the community, learn from what they know, and maybe you know something more on a topic, if not better, something more, maybe because you've labored in that particular field, a bit longer, maybe share it. I think without establishing that rapport, without ensuring that sometimes even there could be perceived hierarchy. Maybe they are looking up to you. Even that you need to ensure you bridge that hierarchy. I think go to the community with an open perspective to learn what they already know, learn from it, not with pretense, wholeheartedly learn from it, because people sense it. And it's good for us professionals to grow with the community, to be part of it. So I think that's the only way for a long-term relationship with the community. 1 hour program, you went there, you talked, you came out. Even if there is a problem, who's going to get back to you and then even talk to you about what they're going through? I think establishing that rapport is an absolute must.
Just to add to what Dr. Ashwini said and what you asked, Banu Mushtaq herself was an activist before she was a writer, and her writings, her stories hit so hard because it's coming from her experiences on the field, and therefore activism and literature sort of go hand in hand. And on any honest story that is worthy of, that would make an impact, would be born of a condition which has closely experienced that kind of oppression. So I just thought that, that writer's background matters here really.
Well, friends, we are actually running out of time. We could take the last question just outside maybe, because the next session has to begin. So, Dr. Brian, you could just meet us outside? Yes? Because we are really running out of time. Maybe you could just tell us the question and we'll come there to discuss it with you. Yes, quickly?
Okay. There were problems regarding dowry.
Hit with the dumbbell.
She was a SWAT, persons in the Delhi Special Forces. My question is, why didn't she retaliate?
Psychologically entrapped, sir. Psychologically entrapped, I mean, let's face it, she's powerful. If your question is she's from that, why didn't she retaliate? So physical power techniques are there, but psychological entrapment strengthened with collective perspective that come what may suffer, where you're married to. I think this is what traps most people. So psychological entrapment, unfortunately.
Thank you for your question. I'd like to thank our panelists for a very fruitful discussion. I don't think the session is over, it's not complete, but we could take it outside perhaps. So thank you very much, Dr. Amit, Dr. Ashwini, and Dr. Chaubey. Yes, it was a pleasure talking to you. Let's do a group picture and then we will step, please.
I thank all the panelists for a truly enriching discussion. I request convener, head of the Department of Psychology, Dr. Mukta Karmadi, to present a token of our appreciation to Dr. Anjali Chaubey. I request event coordinator in charge Department of English, Assistant Professor Ms. Clarinda Dias, to present a token of our appreciation to Dr. Ashwini. Thank you, ma'am. I would also like to request Ms. Clarinda Dias to present a memento to our third panelist, Dr. Amit Dias. Thank you, ma'am. With this, we wrap up with the panel discussion. From now on, we will be beginning with the technical sessions. The technical session, as per the schedule provided to you, will happen parallelly across several venues. Technical session 1 will happen in this hall, Estella. Technical session 2, 3, and 4 will take place in the college premises. Technical session 2 will take place in lecture hall 2, which is located on the first floor. It is also called the AV room. Technical session 3 will take place on the ground floor in lecture hall 3. Technical session 4 will take place in lecture hall 4, which is also located on the ground floor. We have volunteers placed around who will direct you to the premises, to the allotted venues.